Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to discuss a very important topic or a very important field within pediatric emergency medicine. Unfortunately, that is child abuse and neglect. Something that I, as a pediatric emergency medicine physician in Las Vegas, see way too often, unfortunately. And as the child abuse medical director in our hospital, I have been in touch with Dr. Toni Laskey, who is a child abuse physician in Utah. Toni has been tremendous help for our hospital here in Las Vegas, where we see a lot of child abuse. So I asked her to come on the podcast and talk to us about child abuse in the pediatric emergency department. How do we recognize it? What do we do? Who do we call? Etc. Welcome, Toni, to the show. I am super excited to have you because, as you know, this is a topic that, number one, is on our list of I never want to miss it as a PEM provider. And it's a very challenging topic. It's challenging emotionally. It's challenging from a medical standpoint. I think a lot of general EM physicians certainly get challenged by those kind of cases. So I'm super excited to have you on the show. I think this will be extremely beneficial for the PEM Rules listeners. Let me just briefly introduce you, and you correct me if I'm wrong at any point. Toni, you are originally from St. Louis. You completed your medical degree at the University of Missouri Columbia School of Medicine, followed by pediatric residency, just like me, at the University of Missouri Columbia Hospitals and Clinics. And then you completed your research and clinical fellowship, and you got a master's degree in public health at the University of North Carolina at Chapel Hill. Is that right?
Yep.
All right. You are a professor of pediatric at the University Utah School of Medicine and division chief of the Center for Safe and Healthy Families at Primary Children's Hospital, which is a hospital I work closely with. You're also the fellowship director of the Child Abuse Pediatric Fellowship at the University of Utah and the medical director of the Children's Justice Centers of Utah. Did I miss anything?
Nope. That's what I do professionally.
That's what you do. And I know in your spare time, Toni, you like to run a lot and ski, I guess.
Yep. Depends
Anything
on
else? As if that's not enough. Anything else?
I love to travel because then I can ski or run wherever I go.
Very nice. And most recently, what's the last race you did?
I did Big Bear in California.
Which is how many kilometers?
Let's see. A half marathon is 21.1.
21 kilometers. Last time I did that, I was in high school. That's amazing. Very nice. So, Toni, again, thank you very much for your time. I will say on a personal level that 2 years ago when I came to Vegas, I became the child abuse medical director. It's not exactly a directorship position. And Toni has been an instrumental part giving us a lot of help and support here in Vegas because we don't have a child abuse physician. And unfortunately, we have a lot of child abuse, which is why I'm super excited to have this episode. And first question to you, Toni, and if you listened to the show before, you know what it is. What is your definition of a good PEM provider?
Well, I have lots of good examples to choose from. My colleagues here at Primary Children's are awesome PEM providers. And when I was thinking about this question, it occurs to me that it's the collaboration component of it. So it's people that are willing to collaborate in the care of a patient. And also they're willing to go to some uncomfortable places, either direction. So we can see the same clinical information and consider it differently, and we're okay with being uncomfortable with that answer. And the other thing that I think makes a good PEM provider is somebody who comes prepared to answer the questions that I need to know in order to answer their question. So coming prepared with a really good history, a really good physical exam, and knowing some of the key test results so that I can help them think through what else needs to be done.
Excellent. Very well said. And I couldn't agree more. Super important. I teach my residents and my fellows when you call the consultants, give them a good story, especially in the setting of a possible child abuse case. Super important. I agree. I hope we do the same here for our consultants here in Vegas. So thank you for that. And my second question, it's not exactly a question, it's more like a discussion. I remember communicating with you via email a few weeks ago, and I don't know exactly how it came about, but turns out, not surprisingly, that Toni has some child abuse rules of her own, which I think are very helpful, and I'd like you to discuss those rules. I'm gonna read them for the records, and then you can kind of go through one by one. Tell us what does that rule mean to you. So, rule number one: take the time to flip their lips. What do you mean?
So, flipping their lips is part of the physical exam that is going to be something that I ask you as soon as you call for a consult. Have you looked at their frenula? The reason I ask that is because specifically in non-mobile infants, the it's a key finding if you find an injury to either their labial frenula or their lingular frenula. So I need that information to know what my level of concern is regarding other findings that caused you to need a consult. So in non-mobile infants, we know that the labial frenula are unlikely to have an injury from benign causes. So unlike the toddler who's running around like a monkey in possibly with a lollipop in their mouth or face planting onto a piece of furniture, all completely legitimate accidents that we see all the time, non-mobile infants don't do that. So if there was a frenula tear, it would indicate to me that they have something called a sentinel injury, which is an injury that could be an indicator of how they're being handled in general and potentially an indicator of inflicted trauma. So when you're doing an exam, it's a really easy component of the exam. You literally just have to pull up their upper lip, pull down their lower lip, and by the time they're screaming, you'll be able to see underneath their tongue. And if you were to see either an acute injury or a healing injury, that could indicate that something's been shoved forcefully in their mouth, like a pacifier or a bottle. Sometimes people getting frustrated trying to use the blue bulb syringe to suck their mouth out because they might have spit up. All of those things being forcibly shoved in the mouth can tear that frenula. And the other thing that we see torn frenula from is a suffocation or a smothering event, like holding your hand over a baby's nose or mouth to stop them from crying. I sometimes hear the history is that the baby has sharp fingernails and must have torn it themselves. That does not make sense. Lots of babies have sharp fingernails. We see that all the time. It is not an injury that is plausibly explained by self-inflicted trauma.
Excellent. That's really really good information. Exactly why you're here this morning. Thank you for that. Yeah, super easy to do, and it is my understanding, Toni. I came across a paper a few weeks ago that the finding of a torn frenulum is specifically more concerning if it's seen in conjunction with some other sentinel injuries. Is that right?
Yes. So specifically, if you've got a history of blood coming from a non-mobile infant's nose or mouth, I'm always thinking, where did that blood come from? And it's really important to thoroughly evaluate the frenula, because if that frenula is torn and say, for example, they have a single isolated bruise somewhere else on their body, now you have two injuries that are not plausibly explained by the things that a non-mobile infant can do under their own power. So you have to start thinking, has something happened to this child?
Excellent. Very good. Thank you very much. So that was rule number one. Rule number two, very interesting. Don't just look in the ears and eyes. Look at their ears and eyes. What do you mean by that?
So this is funny because I think about in pediatric residency, I don't know if you had this experience, but we spend so much time trying to see the landmarks of the eardrum. And I think in the beginning, when you're an intern, you're just saying that you see it. Like you have no idea what you're looking at, right?
100% true.
Right. And then the optic nerve to me was even harder. Like I don't know that I saw an optic nerve until well into my fellowship. So we spend a lot of time learning about how to look in the ear and in the eyes. But in the evaluation of the potentially abused child, you need to consider the information that's easily available, which is right there in front of you without doing any special maneuvers, right? So thinking about sentinel injuries again, the eyes, you're looking for subconjunctival hemorrhages. And when you're looking at the ears, you're looking at the pinna itself, because the pinna, if it has bruising on it, is very concerning for trauma. That's how bruises happen, is trauma. Now, mobile infants, again, thinking about that crazy toddler running around, they can fall and injure their ear. I will say it is highly unlikely that they will fall and injure both ears. So when you have bilateral bruises to the pinna, it causes me to be concerned that somebody's using their ears as discipline, right? They're grabbing the ears, twisting, pinching, hitting. But in an infant, again, non-mobile infants aren't doing very much, so they're not going to have bruises on their pinna. And there's good research that shows us bruising to the pinna in a non-mobile child is highly concerning for inflicted trauma. And then thinking about subconjunctival hemorrhages have so many urban myths associated with them. It has frustrated me for some time that people are like, oh, babies vomit or babies are constipated, and that can cause subconjunctival hemorrhages. We really need to put those to rest. And I will tell you, really good clinicians aren't aware that the research has been done that shows constipation, coughing, vomiting, and crying do not cause subconjunctival hemorrhages. In rare cases, extreme coughing, such as associated with pertussis, may cause subconj, not often in infants, more likely in children who can really generate those intrathoracic pressures. But in an infant that has subconjunctival hemorrhage, the thing I worry about is a squeezing injury of the chest. So somebody squeezing the chest so hard that rib fractures are something we need to think about. Confessions have told us that people do it because they want to make the baby stop crying, but also suffocation and smothering causes subconjunctival hemorrhages. So when you see subconj, you really, really need to think about inflicted trauma first, because it's an urban myth that the common things that we think of in pediatrics, like coughing, vomiting, crying, and constipation, are the cause. That is not very likely that that's the cause.
Excellent. And I got to tell you, I recently sat in one of your lectures where you discussed that information. And as a PEM provider, it makes perfect sense. I wish I had $1 for every child I saw with really bad cough. Never seen conjunctival hemorrhage. I've seen dozens, maybe hundreds of kids with pyloric stenosis, probably the most high pressure vomiting ever. I've never seen subconjunctival hemorrhage. Crying babies keep me busy. I've seen thousands of crying babies, never seen conjunctival hemorrhage. So from my anecdotal experience, I can and totally relate to that rule. Very, very important. Very, very interesting to hear.
I do think I want to remind people that obviously in the perinatal period, obviously birth is traumatic for both mom and baby. No matter what the gynecologist obstetrician documents it as is a non-traumatic birth. It is traumatic. Having your head squeezed can definitely cause subconjunctival hemorrhages. And in fact, a colleague of mine just had a baby by C-section with a tight nuchal cord, and that baby was actually born with a subconjunctival hemorrhage. So it's important to remember in that perinatal period, subconj is associated with birth, but it's going to be present at birth. Now, it may not be documented at birth because we don't always document the things that we consider benign. So if you're in that first 2 weeks, remember there is a differential diagnosis that includes benign conditions.
Excellent. Very good. Thank you very much for that. That's actually an excellent example. Rule number 3, more has to do, I guess, with the medical legal aspect of child abuse. Write what you saw, heard, or did precisely.
Yeah. I like to say that the medical record is not a place for creative writing. I frequently read medical records as I'm preparing to go to court, and it'll talk about this lovely mom brings in her adorable baby. Like I'm great. It's great that you can use adjectives. It's not helpful to understanding clinically what's going on. And writing what you saw, heard, or did precisely is really, really important because there's well done research that shows us the most common cause of a changing history is how the healthcare provider asks the question, how they document the answer, or the use of interpreters. So I think that we use the word that people are lying too easily. The reality is it's confabulation. It's human nature to try to make sense of the information that you're given. And when somebody gives you a story that's missing pieces, you just naturally fill those pieces in. It's not that they lied or you're making things up. You're just filling in the pieces because that's how our mind makes sense of the world. So when you have a history of trauma that you're trying to get from a caregiver, they're telling you something that makes sense to them. And it may include information that is or isn't necessarily actual fact. It's just information that they have deduced. And so I think it's really important to think about when they're telling you the history, do I really understand what has been said to me? And can I accurately capture that in the medical record? Now, does that really matter when you're dealing with a kid who's got like a viral gastroenteritis? They've been puking, it's been happening for a couple of days, and the diarrhea started. Like, this isn't a legal situation per se, but in a history of suspected child abuse, when you document what the history was, and then the next person documents a slightly different version, and then by the time they get to the consultant, we have a completely different story, people start throwing around changing history. And the reality is that it was nobody sat down and really tried to understand or document accurately. And then that starts causing us to believe that somebody's lying to us when in fact it could just be confusion. So what I recommend to providers is doing the repeat back, really making sure you understand. So thank you for sharing that with me. I really want to make sure I understand this. You told me that you put the baby on the bed like this and you turned away, so you weren't looking at the baby anymore. And then you heard a thump, and when you turned back, the baby was on the floor face up. Is that right? And they're like, no, 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 no. The baby was face down. Be like, oh, thank you for clarifying that for me. Because again, you're really trying to understand the mechanics of what happened. And one of the tools that I use is I like to have somebody else in the room with me because we hear and interpret things differently. So whether it's a learner, I've got a resident or a medical student or a fellow, or I have my nurse or my social worker, literally, I make it so that anybody can clarify the history so that we all have the same picture in our head. So if I repeat back and I think I understand, but my social worker says, Dr. Laskey, that's not how I understood it to happen. Can I clarify something? And we keep doing that until we iteratively, genuinely have some understanding of what information was provided.
Excellent. Yeah, very, very, very important. Very good tips. I got nothing to add. This is super helpful. Um, Moving to the next one. Did they see it? Did they hear it? Did someone tell them? What do you mean by that?
Okay, so this links directly to the previous rule. When we take a history, we assume that we're taking history from a primary source because we only have, the caregivers that are in front of us, right? We're not calling every possible eyewitness. So what I need to do is I need to understand, how do you know the information that you are providing to me? Say, for example, the mom had left her 14-year-old in charge of the baby, and the 14-year-old relayed the information to her. 14-year-old's not present, so the information the mom is giving you is the way that she understood it to be told by the 14-year-old, which may or may not have been clear or accurate at the time. So when I'm taking a history, I like to start out with, okay, can you tell me before we get started, did you see it, did you hear it, or did somebody tell you about it? Because the quality of the information is going to be variable based on those characteristics. If somebody saw it, you can assume that they're relaying the information to you as they actually witnessed it. If they heard it, they often will fill in the pieces that they deduced based on hearing something and then knowing what the before was and the after was. And if they're telling you like essentially third-hand information because they weren't present, that really qualifies the history that you're getting, because now the history that you're getting is a game of telephone, right? They weren't necessarily able to clarify anything, or they just assumed some facts not in evidence. So I really feel it's important, if somebody's telling you information that they did not personally hear or see, qualifying that in your note is going to help everybody downstream to not put too much weight on that, because the information is secondhand to begin with.
Very interesting. You know, as you're saying all those things, I think it becomes very, very clear to the listeners why, unfortunately, child abuse is its own fellowship now. You are a physician, you are a clinician, you are a detective, you are a social worker. It's really interesting because as you say all those things, you can really tell how this is so nuanced and so challenging and so complicated. So I really appreciate those tips. Those are excellent. Lastly, I got to say my favorite rule, and the one I think I struggled the most being a non good writer, objectively document, don't subjectively speculate. What do you mean by that?
So this one comes from my clinical experience in evaluating injuries, where in my head, I can think of ways that a certain injury could have been caused. But if I say that this is the way that the injury was caused, that really narrows the diagnostic window for both healthcare providers and investigators. So it's an anchoring bias. So, for example, if you see linear petechiae on a child's face, in your head, you might be thinking, wow, that looks like a slap mark. But the reality is that you can cause those exact same injuries from either a slap or a grab. If you've got a kid who's verbal and they're able to relay that history in a forensic interview, that their caregiver grabbed their face and squeezed it to make them stop talking, and you said, no, this is a slap, now you have a discordance between what you say is the answer and what the child said happened. So rather than subjectively speculate, it's important to describe what you see. I see linear petechiae on the child's left side of their face. I really believe in photo documentation so that we can all be working off of the same information, because I may not be able to describe it well enough for you to actually see it with your head. But the other thing to think about is like, again, paired linear bruises on the back, that could be from a belt. Or it could be from like a paint stirrer. So, right, the wood paint stirrers, those could be the width of the belt, but you've just limited what caused it by saying this is something when you don't actually know. So taking pictures is the number one part of this, so that we can all objectively be working from the same information. You can suggest things that might cause something like that. So, a handprint is a handprint, but you don't know whether that was a slap or a grab. But really, it's important to not overly diagnose something that you don't actually have firsthand information about.
So, do you recommend saying something like linear petechiae concerning for a handprint, or just say linear petechiae?
So it depends. Like sometimes you can see the perfect handprint, right? You can see the fingers and everything. I have some unfortunately good teaching examples of that. If you see a hand, document that it's a hand, but I would not say this is a slap, because you don't know that it was a slap. You just know that it's a hand. When you see linear petechiae, the way I describe it is there are linear petechiae on the left side of the child's face. These could be consistent with either a slap or a grab.
Excellent.
Because that way you're encompassing a range of possibilities.
Excellent. Yeah, those are super helpful tips. I think, again, this is something that we always worry about our documentation and where it's going to lead to. So these are really, really good tips. Lastly, Toni, I'm going to ask you sort of like a summary question. I think I speak to a lot of ED physicians that refer patients to our PGR for child abuse and whatnot. And just in general, I always have like in all my charts, at least a paragraph or two at the end, summarizing the visit, what happened, what I think, etc. How do you recommend us documenting at the end of the encounter if there is a concern about child abuse? Give us like a good tip about sort of a summary statement for a chart that I think could be secondary to a child abuse type of visit.
So I want to acknowledge that my colleagues in the emergency department are frontline providers, right? They're working with the information that is freshest, and they don't have necessarily the time to really dig into all of the different nuances like a consultant would. So leaving possibilities open is important. When you have a concern for inflicted trauma, I think it's important to say, the findings identified, including, I like to re-summarize what your findings are, because we teach people to look at the assessment and we sometimes forget to go back to the actual core data of the physical exam. So restate it and say, these findings raise the concern for trauma, remembering that trauma comes in more than one form. So you could say these findings raise the concern for trauma, which may be accidental, as yet unidentified, or inflicted. Additional evaluation is warranted, or additional consultation is warranted. Because if you are at the very earliest stages, like we know rib fractures happen from trauma, right? Like they do. Subdurals happen from trauma. The reality is you might be early enough in your diagnostic journey that you don't have enough to say for sure which direction this is going to go. On the other hand, you may have plenty of information. If you've got a kid with a subdural and rib fractures and bruises all over, you will know that the highest thing on your differential is abuse. And I think stating that is really important, because there are people that are dependent on your documentation in order to know what the next best steps are, including child welfare, who is going to need to know sooner rather than later that they need to figure out what's going on. So say, for example, you've got a kid with multiple injuries that the leading diagnosis is child abuse. Then saying that, these findings are consistent with trauma, there is not a likely plausible accidental mechanism to explain the totality of these findings. When we're overly obscure about what our thought process is, it makes it very hard for the system to make sure that children are safe. And furthermore, when it gets into the system further, it's interesting that lawyers will frequently say, Dr. Laskey, why are you the only one that is calling this abuse? Everybody else is saying that there's this differential diagnosis, but nobody is going as far as you are. And I feel like it's because everybody's afraid of answering the question. So they leave it as this big differential, but they don't actually say, we've got enough information now to know that this is what our answer is.
Excellent. No, I couldn't agree more. I think, like I said earlier, this is a topic that makes even PEM providers very uncomfortable and kind of scared. I can't even imagine in general ED physician that doesn't see kids very often. So super helpful. You came on the show. Thank you so much for all those tips. Those are really, really helpful. And I think you know the drill by now. You know the show a little bit. The guests get to choose the outro I will play in your honor of you coming on the show. And I'm guessing, seems to me that like most of my guests, you were a teenager in the 90s.
Oh, 80s. Thank
80s.
you.
Okay.
80s.
You're welcome.
I'm an 80s girl.
You're an 80s girl. So I can do 80s, any kind of artist or song that you would want to hear on the outro. As long as it has guitars and drums and bass, I can maybe do it, hopefully. Don't say Billy Joel. I have a guest who likes Billy Joel. Impossible.
My favorite song of all time is Steve Miller, Abracadabra.
Steve Miller, Abracadabra. I can't say that I know the song, but I'm going to look that up.
Goodness.
Listen, I was a teenager in the 90s. So I'm going to do my very best and get that song for you as an outro.
Okay. Thank you, Yaron.
Thank you very, very much for coming on the show. This was super helpful. Super appreciative of your time. Thank you. And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Toni and her great wisdom and experience on this very important topic. As usual, if you have questions, concerns, want to come on the show to talk about any topic that we PEM clinicians will benefit, please let me know through the website. I'm always happy to have guests. I hope you continue to listen to PEM Rules. Check out the website, check out the Facebook page. There's now a PEM Rules store online for some swag. Not a whole lot there, but something. And again, thank you very much for the support. Really appreciate it. And here is Abracadabra directly from the 80s. Toni, thank you very much for that choice. I actually do know the song. And thank you, as usual, for my keyboardist, aka my son, to help me with the keyboard. Thanks again. Have a great day.